we've been doing the report as we have for many years, and with some of the focus from Australia on supplementary reports and things, Tim, is that something that perhaps we could be looking at and get feedback from our surgeons as to areas of interest that we could focus reports on?
Yes, I think that there are lots of changes we could and some of them that we should make. The report has grown and grown and grown. It's not only because it was taking in more different joints, but because there's just more analysis done. And we've tried to hide that by not producing a paper version under the guise of protecting the environment. But really, people need to be able to read the whole report, and therefore I think the whole report needs to be shorter, and therefore we probably need to produce separate and focused reports to go along with it, and some other information, because at the moment we've got lots of information that we want to produce and which we don't put into the report, but it can be put online. So I think we're going to be changing the way in which we do it. We will make more information available, but perhaps in a different and more bite-sized chunks.
I think the report has fallen victim over time to being like hospital induction. People only ever add to it, they never take things out.
Hi, David Johnson from Stockport. As you know, I'm a big fan of the NJR, and clearly the revision rates have fallen as time's gone by. In my clinics, I've noticed an increasing number of patients I'm not revising, ones who are unhappy. Our revision rates have gone down because we're doing better implants, but I'm probably seeing twice as many unhappy patients I wouldn't revise. When are we going to see problems as part of the NJR report?
Well, interesting to relate that I think that Tim Briggs isn't with us, perhaps for the first time for the last 10 years. It's in his hands. We have been berating the NHS England and NHS Digital teams endlessly for the last 6 years. We have now received some information which Chris has repeatedly had to go back to them and say, yeah, that's fine, but it doesn't actually contain all of the prompts that we were sent 5 years ago, so where are they? We're getting more information. We hope that we're going to get even fuller information, but really one of the problems is that because this information has not been fed back to us or to the trusts by NHS Digital in the last 5 years, that people have grown tired of collecting it. So actually the numbers collected were up to 60% some time ago, and now have diminished to about a third of that or less. So I think we need a new start. We've been offering for several years that the NJR would collect that information for NHS England and give it to them. Then we would have some control over it. We haven't met with much success.
I would suggest go and look at the problem section we put in the annual report 3 or 4 years ago. So even before the disaster, the problems data, you know, the kind of completeness of having valid pre-op and post-op data was kind of 30-odd%. But if you look at the patients that we have problems for versus those that don't go through linkages, there's different rates of revision and mortality in the groups. So the problems data you would present is not representative of every patient having a joint replacement. So you just need to understand that when interpreting that kind of data. And 30 to 40% is not bad for national market survey work. So, you know, much as everyone's like, oh, well, why is that so poor? It's not bad response rates for that kind of stuff.
But David, as I think Mike Reed pointed out in his talk here 5 or 6 years ago, it's really important, because what you say is we're doing fewer revisions, but there are unhappy patients, maybe increasing in numbers of unhappy patients. And from the hospital's point of view, from the patients, and from your own point of view, you need to know that. So you would much rather be somebody with a low revision rate who had average PROMS improvements which were dramatically good. If you have a very low revision rate and you have average PROMS improvements which are dramatically bad, perhaps it's just that you need to adjust your threshold for revision or send them to somebody else for revision. And that's why we need this information.
I mean, one of the interesting questions would, you know, it would be good to look at is the threshold for revision when you're seeing someone else's patients rather than your own. But that's
I wonder what that would be.
That's also an important part of the whole network and NDT thing that's going on at the moment is that it isn't just the individual making that decision, that there's more transparency. So we're hopefully getting better at setting that threshold.
Hi there, David Hill here from Liverpool. Just touching on the CLRs, obviously for primary stuff and trauma, you talked about the osteoarthritis and the trauma. How does it deal with the situation for what's not strictly a revision, but going from failed trauma, which you can tick as chronic trauma, can't you, on the list, where you then go into essentially a primary arthroplasty situation, but it's not really, it is a revision, but there's never an H1 for it.
Yeah, so I mean, obviously you've seen the move of the failed hemiarthroplasty convert to total from a primary form to a revision form. That was directly led by the fact that we had to have what you call sequence of events. So when NGR wasn't capturing hemiarthroplasties, we had no record of the primary. Now that it is, we have the record of the primary. So, you know, some of the most complex cases I've done have been conversions of hemis to totals. So I'm more content with that being on that form. The modifier at the moment for us is that those go in under the other indication in terms of the revision ratio, and the osteoarthritis is such a dominant indication for surgery that actually there's not much you can do in terms of that adjustment. So the most balance that we found is having osteoarthritis as group, trauma, which is acute and chronic, and then other as the kind of groups that you're stratifying effectively into. For the mortality analysis, the acute and chronic traumas are excluded. So that doesn't reflect, and you know, kind of, we had the debate around when hemiarthroplasty started being included, people getting pinged with loads of 90-day mortality notifications. And you know, kind of, I felt that was a bad thing because it would stop people looking. But you know, we spoke to our patient groups about it, and they said, well, we want surgeons to know, which is not unreasonable. But those aren't going into the report, and I think we've got better with messaging around that to make it clear, you know, which do and which don't count.
So revising, say, a failed femoral nail is cut out to...
Put it in as chronic trauma, that then goes in, it gets, you know, effectively an adjustment factor for being in that trauma group, rather than just the OA group.